Welcome to Belgrade and to this great workshop supported by European Confederation of Clinical Microbiology and Infectious Diseases. It's my great pleasure to welcome you as a student and attendants, and also all lectures which help us to establish this great program. As you already know, we are planned to have several lectures, but also two workshops after the lunch. The lunch will be between 1:30 and 3:30, 2 hours for the lunch, in the beautiful place Skadarlija. And after this, we will come again here to have practical work. After that, some of you who wish to visit Museum Nikola Tesla can registrate on the desk. Now I want to thank my friend and colleague Tadeja Matos from Ljubljana. We are friend and colleague more than 20 years exactly. I went there in 2006, and she will chair this session. Thank you, Tadeja.
Thank you. Valentina is here for
I will be here. Yes, thank you. This is my lecture.
So microphone I have to use.
I think.
Right.
Just okay. Put on the desk. Yes. Okay.
Okay. Okay. Thank you. So good morning, dear colleagues, friends, also from my side. And thank you, Valentina, for kind introduction. So it's my pleasure to chair this session on personalized mycology and fungal infections. Our first speaker is Professor Valentina Arsić Arsenijević from University of Belgrade, and also coordinator of this course. So she leads National Reference Laboratory for Medical Mycology and is actively involved in research on invasive fungal diseases and fungal diagnostics. So she is also the principal investigation of the Fungal Case Finder project and one of the leading experts in medical mycology in this region. So her lecture today is entitled Personalized Mycology, Needs for Fungal Case Finder Platform and Tools. Please, Valentina.
Thank you very much for kind introduction. What this lecture cover today? First of all, something new maybe. This is 4P medicine. Then some introduction regarding medical mycology, about fungal infection and diseases and epidemiology, clinical aspects, laboratory diagnosis, but finally we will discuss about new platform. We give the name Fungal Case Finder and what it means in platform of something new we call personalized mycology, and which challenges we are expecting, but by follow this project and results of these projects. As we know, the medicine is built in the way one size fits all. But the true data show us that one size doesn't fit all. And based on this, the new concept for 21st century is 4P medicine, which means prediction, prevention, participation, and personalization in medicine. And during this project, founded by Scientific Fund of Serbia, we try to give one relationship between 4P medicine and medical mycology. As you know, medical mycology is a very interesting part of microbiology, but mostly with low experience and with low knowledge for clinicians and microbiologists. And based on this, we try to focus on several key issues. This is dermatophytes mold, which are very prevalent all over the world. Then yeast, opportunistic yeast, such as Candida and somewhere Cryptococcus, and also non-dermatophytes molds, which one of the main is Aspergillus. Key aspect of medical mycology is some pathogenesis, risk factors which related to the patient's diagnostic, which can be clinically oriented, visualization also is very important, but the major things are how to prove fungal infections, especially in severely ill patients or in patients under risks. And also treatment, but for this course, treatment is not our focus. As you know, about 100 to 600 fungal species can cause infection and diseases in humans, but about only 30 are very common and most important. And something that is important nowadays is fungal biomarkers. Fungal biomarkers, we will, maybe you can see here much better in this slide, is some soluble molecules that we can detect but by several laboratory diagnostic platforms, especially in invasive fungal infection and diseases such as beta-D glucan, galactomannan, mannan, or glucuroxylomannan. But also, this is very important to understand that some of cell wall components of cytoplasmic membranes or nucleic acid structures are important target for antifungal drugs. And what is important? Important that animal cells, such as ours, doesn't have a cell wall, and for this reason, cell wall is very important target for antifungal drugs as well for diagnosis, for laboratory diagnosis. And by using this P4 concept, I already explained what is important prediction, especially in high-risk patients, in order to prevent these diseases, then personalization, and finally participation. And participation means that any patient or human need to be educated regarding about these infections, and also to be able to participate in scoring risk, and also to take a sample. And the final results of our project will be how to take a sample in home or bedside testing in clinical settings. As you already know, epidemiology of fungal diseases are well estimated, and superficial fungal infections are very common. About 1/4 of all world population have some kind of fungal infections, usually skin, nail, or mucosa. But in some settings, such as intensive care units or hospital, or some hospital settings, especially hematology or oncology settings, invasive or severe fungal infections can occur, and the problem is that they have common fatal outcomes if not suspected, if not diagnosed, and if not treated. As you already know, superficial fungal infections has low mortality, or we can say that this is without any mortality in previous healthy patients. But for invasive fungal infections, the fatality rate is very high. For example, for 40% for invasive candidiasis, up to 90% for mucormycosis or some rare molds. The most common clinical spectrum of superficial fungal infections are ringworm, Tinea pedis, Tinea cruris, onychomycosis, vaginal yeast infection, and oral thrust or stomatitis. And for invasive fungal infections, usually we have sepsis or fungemia, Hebedosplenic candidiasis, or lung infections. What is the biggest problem with fungal infections? This that number of some yeast can be part of microbiota. The example is Microsporum Malassezia species or Candida species, but also some rare yeast. From the other side, we have superficial fungal infections with typical or characteristic clinical signs and symptoms. But finally, very rare but very dangerous invasive fungal infections, which are usually clinically is not characteristics, and for this reason, collaboration between physician, microbiologist, and epidemiologist is very important. Beside infections, some fungi cause allergy. Allergy are usually in previously healthy people, in outpatients, and the most common clinical spectrum is chronic sinusitis, allergic bronchopulmonal aspergillosis, and sometimes fungus boll also is not related exactly to allergy, but this is something that occurs in the lung and can be mixed with some malignancy or some other pathogens. Now we go to the laboratory diagnosis. What is important? We have at least 4 platforms for laboratory diagnosis. One is cytology, the second is culture of patient sample, then detection of antibody of antigen by using the immunological platform, and finally molecular-based tests. Usually the most usually used is PCR test. But from laboratory and clinical point of view, the standard methodology based on the microscopy or cytology and culture is the most important, because these 2 traditional platforms can give us proven fungal infection. What is the problem? The problem is low sensitivity. And for this reason, nowadays we try to use also other problems, other platforms such as immunological or molecular-based platforms. Due to low sensitivity of traditional microbiological methods, we usually use combination of several different platforms to give highest specificity and to exclude false positive results due to contamination, which is very common because fungal are everywhere, and due to highest sensitivity. And the other thing that we find as a problem is biofilm-forming fungi. These biofilm-forming fungi, also bacteria or other pathogens, are very difficult to detect because they are covered with some protective layer, such as which is prevent immunological systems to control infections and also prevent effect of antifungal or antimicrobial drugs. Usually we do sampling by swabbing, and also we know that this is not a representative method of sampling, because swabbing is not a very strong or useful method to scraping superficial enough patient sample from superficial, and is unable to detect biofilm forming fungi. And we come to one idea to create fungal case platform based on at least 3 things. First is mobile app, and you will be able to test this platform today in the last session. then one software oriented to the laboratory or physicians, and finally tools which allow us to take the best sample and to destroy biofilm forming fungi. And all these following the rules of personalized medicine, but now we put this in focus on personalized medical mycology. And now, in the second part of my presentation, I will introduce this project, the key idea, and also the key findings. We create this project to estimate some risk in our patients, and to group them in three groups: low, medium, and high risk. Then we tested all patients by traditional method and also by new design fungal case finder tools. We estimate or we create some platform to scoring this risk, and also platform to collect all laboratory data in one software in order to analyze these results. This proposed solution based on innovative tools have some better test performance, as I show on this slide. But the key idea is that we want to show that planktonic fungi is easy to collect by swab, and also by scraping. But this biofilm forming fungal is much easier to collect by this new tool. And also we can calculate the volume and to perform transfer much better than we use swab. We have 4 group of patients: vulvovaginal candidiasis, sinusitis, chronic sinusitis, onychomycosis, and we collect number of patients. I show here only one group for stomatitis, and some of these results which we presented here with our colleague from Faculty of Dentistry, and we find out that more positive results occur by using fungal case finder. Then we got several mixed culture, more than one Candida species, and finally we were able to detect biofilm producing fungi. Fungal case finder mobile apps you can test today, and I will skip this for now. And also this software is protected, and fungal case finder app is free for use, but this software is protected. And now we have only in our local language, but we are preparing to translate this to the English. Stomatitis, vaginitis, sinusitis, and dermal infections, focusing only on onychomycosis. The first part of this software is patient data, demographic data. The second is medical history, risks, some other chronic diseases, therapy, treatment, and but the final focus is past fungal infections or skin and mucosa. And if we have some characteristic clinical part, for example, here is onychomycosis, we are scoring some most important challenges or clinical findings on nail. And finally, the last part of this software is a laboratory part. We in parallel we sample by traditional and fungal case finder method, and we put these results for further analysis. In the perspectives, we expect a number of applications, but the most important is a reduction of illness and death, and establish of a new platform called personalized microbiology. And we hope that we can prevent, especially by using these invasive fungal infections, which are very important in clinical settings. During these 2 days, my colleagues will talk about findings of this project, and the most important thing is that this project attracts many students. And also I want to thank my dear friends and colleague, Professor Mihaj Mareš from Jaši. We start to organize this local community or regional community to help each other in this very difficult but beautiful field. And I'm happy to inform you that the next 4th Balkan Conference, Balkan Fungus 2026, will take place in Napoli, Romania. Thank you very much for your attention.
Thank you.
Question during the break.
After the session,
after the session. Yes.
Okay.
Is it okay? Okay.
So thank you very much, Professor Arsenijević, for the interesting presentation. And so we can move now to our next speaker. It's Dr. Novica Nikolić. So he's an anesthesiologist